So good afternoon, everybody, and welcome to Psychiatry Grand Rounds. My name is Tony Rothschild. I'm the chair of the Grand Rounds Committee. Just a couple of brief announcements. In order to receive credit for attending today's lecture, please complete the survey evaluation that was sent with a SurveyMonkey link from Karen Lambert with the Grand Rounds announcement this past Monday. If you have questions for today's speaker, please type them into the chat function and we will ask the speaker the questions at the end of her talk. This is the last Grand Rounds of this academic year. The next Grand Rounds will be on September 8th, 2022, and the speaker will be Dr. Kimberly Yonkers, who's the chair of our department, to always give the inaugural Grand Rounds. We are planning to have Grand Rounds in person starting in September, but it will still be available on Zoom for people who are far away. It is my pleasure to introduce Dr. Edwin Boudreau, who many of you I'm sure know. Dr. Boudreau is a professor in the departments of emergency medicine, psychiatry, and population QHS. Ed will introduce today's speaker.
Thanks, Tony. I am thrilled to have Becky Stoll here today. It was supposed to be in person. Unfortunately, it's not, but Becky's one of my heroes. So I've worked closely with her for quite a while now across many states across the nation. And every single time I work with Becky, I learn something new. So that was one of the reasons why I thought she would be fantastic for Grand Rounds. So she's walked the walk. That's what I love about what Becky does. She has worked tirelessly for about 10 years now to transform Centerstone, the organization she works with, into one of the premier mental health organizations in terms of suicide prevention. And she's done this by helping to take the best and evidence-based practices in the science of suicide-related care and to implement them during routine clinical care in a very challenging and very busy setting. So I think she has a lot to say about how to do this. And I think that we'll learn a lot from what she's going to summarize today. So, Becky.
Great. Thank you, Ed. Let me make sure. There we go. All right. So good afternoon, good morning, good midday, folks in Boston. I'm Becky Stoll. I'm a licensed clinical social worker. I'm sitting here in Nashville, Tennessee, which is currently kicking off its CMA festival. So we have been converged upon with tens of thousands of country music fans. So I probably will not venture out further than where I'm sitting right now for the next week. I'm here today to talk about really how we developed and implemented a zero suicide framework into the operations that we see here at Centerstone. I'm our vice president over suicide prevention and crisis services and disaster mental health. So I'm going to give you all a lot of information over, probably about the next 50 minutes, and then we'll leave a bit of time for question and answer. Hang on, my slide. Oh, there we go. I have my disclosure. I have no conflicts of interest to report for today's presentation. Let me tell you just a bit about Centerstone. We are a very large behavioral health company that operates in and outpatient clinics in 4 states. We have a military services division that we work with the Stephen Cohen Foundation on. We operate a lot of their military clinics. We have a research institute. We have our own foundation. So we're a very large behavioral health system. So in 2012, the second national strategy for suicide prevention came out, and it included what was left out of the 1999 National Strategy for Suicide Prevention that came out from the Surgeon General's office. And these 2 additions were really goals 8 and 9 that were added. And what it did was correct what many thought was a big miss in the 1999 strategy that didn't talk about healthcare. And it never really tied how healthcare has a responsibility in this space. And that we really should be screening and assessing and providing sound care to individuals who enter our systems that might be at risk. So this has kind of been the guide map since 2012 for the nation. Around 2012, 2013, this notion of zero suicide emerged from the Henry Ford Health System when they were working on a perfect depression care program. They didn't start out doing suicide prevention. What they started out was saying, how can we make sure our depression care is perfect? And a nurse said, well, that means nobody would die by suicide in our system. And that's really where the seed was planting at this. So zero suicide really looks and says that people that are being seen in our systems of care on the physical and the behavioral health side, that these suicides can be preventable. It doesn't say they are or is, but it says they can be. And we should be leveraging everything that the system has to offer to try to prevent people from dying alone and in despair. So this zero suicide framework is really a model of how to tackle suicide prevention within an organization. And it's not meant to be bolted on to a system of care. It's really meant to be baked in or woven in to the very fabric of the operations of your services. And it sets zero as an aspirational goal with the belief that in a just culture, the system is what's held accountable when we see an adverse event, because we're leveraging the whole system. If we have an outcome other than zero, we should be looking at it from a systems perspective. Really, it also was the first time that it seems that suicide prevention was looked at as a focus, much like the medical field, where it's an error reduction and it's an issue of safety, that we really look through this lens of error reduction and safety, much like is done on the medical side of care, where hand washing and wrong site surgery and things like that were really tackled on the medical side, that we can do better in the suicide prevention space when we overlay what we know from science and research tells us, and we implement those across the operations of what we do. It also acknowledges that the road of mental health is paved in Swiss cheese. And I often think, I show this slide a lot, and I often think about it laying down like a road and being more horizontal. You all know that work in behavioral health, it's a tough system to navigate. It's hard to get appointments. Care coordination is not great. And when we allow someone who is suicidal to navigate, almost in an obstacle course-like way, these very gaping holes in our system, if we can't fill in some of these potholes, we're going to see injury and death. And what the zero suicide framework is attempting to do is pave over some of these holes in the buckets that you see at the top, so that we can help people avoid suicide attempts and suicide deaths. So thousands and thousands of systems across the world really have adopted this zero suicide framework and are embedding it and implementing it into their systems and their operations. And there are success stories out there, and people that are adopting this framework are seeing decreases in suicide deaths. And they also note in some of these articles that I've listed that the fidelity to the model really is associated with lowering the risk of behavior. And I'll talk about fidelity in a moment. But if you build it and your folks don't do it, that will become very problematic. And you can't really say that you're operating within the suicide prevention framework. But we hope by embedding this and overlaying it into the system and having it marinate into your operations, that you really can see a reduction in suicide attempts and suicide deaths, as some of these other systems of care have seen. If you want to see some of the outcome stories, I put the link in here for you. But the systems of care that have begun to use this are seeing these benefits here. You know, we are seeing reductions in deaths, hospitalization rates on the inpatient side, seeing individuals, because we're doing better care coordination, show up for aftercare appointments and avoiding one of those potholes that we have seen. And at the end of the day, some of these initiatives also save money. So it's a win and a win. We're providing better care, helping people navigate the system. And there are cost savings. We did a couple of studies with follow-up programs that we did, and we saved hundreds of thousands in a year and almost 3 million in a couple of years in a program that we ran. When you do this in a little bit more thoughtful and methodical way. So what is it? The Zero framework looks like this. It's 7 elements or 7 pillars of care that you don't have to do in a linear fashion. They kind of swirl around and you're paying attention to them in higher intensities at different times. But it's this holistic approach to taking everything that we think we know and injecting it into the system so that we can see better outcomes for the individuals that we're caring for. And not only are we preventing suicide deaths, but we're also helping people build lives that they feel like are worth living. I know at our organization, we've really tried to embrace that notion that we're not really here just to keep people alive. I have sat in death reviews and looked at cases and what's going on with people who've died in our system. And to be honest, I wouldn't want to live these lives either. Very painful. So we have to find a way to prevent death, but also to build lives that people want to live. So let's jump into the first pillar. And in each one of these slides, I've put, there's a really good Zero Suicide Toolkit on the Education Development Center's website, who operates this. And if you want everything you ever wanted to know about all of these pillars, you can go onto these links. But let's talk about culture and leading kind of a system-wide transformation. So I often think about each one of these pillars as a cylinder that has to be filled up, almost like you're raising money for a charity and you want to take a magic marker and get all the way to the top and shade it in really dark. And it's a good way to assess how you think you're doing in each one of these areas. This is one I think you constantly have to keep shading it in because it fades. And you have to pay attention to the culture and the lead, or this is one that will fade on you and you'll have to keep looping around and making sure you're doing the work. So you don't really kind of get ready for change, achieve change, and then go, whew, I'm glad we got done with that and put a check mark by it. It's one that you have to work to kind of maintain your commitment and your readiness for change to do that. A lot of what we found to do that was having this tilling of the soil. You know, what are we doing ahead of time before we implement things that we want to implement to get the system ready? And if you're in a constant state of till, plant, the culture and the leadership piece kind of take care of themselves because you're doing it in a way that just fosters that. But it really makes you lean into that you're not only developing the system, but you also have to pay attention to implementing. It's not just the what, but it's also the how, because the what's pretty simple sometimes, but how are you going to get this to stick and become a permanent tattoo and not a temporary tattoo? Some of the things I think that can help with that are having a standing suicide prevention committee that's made up of, you know, the people that need to be at the table to help you navigate these waters. We have an assigned director of suicide prevention. I know some entities don't have that, but we have found that incredibly helpful to have somebody on point for all of these efforts. but those are both very high level. So how do you have that tube that goes back and forth between the folks doing the work and the people making the decisions about how the work goes? You know, I think about it like when you used to could go to a bank and go to the drive-thru and you'd shoot a tube up and they would shoot a tube back down to you. And we found that having zero suicide prevention champions was a way to go. And that entails having every program that we operate has one person that's the zero suicide champion for their location or their program. It's often mostly not supervisors. It's somebody that finds suicide prevention kind of groovy and they like it and they want to be a part of it. And then we kind of have made them, they're deputized to be the representative for the efforts. And we meet with them monthly so that we can shoot information down the pipe and they can push things back up so that we make sure we have the feedback loops that we want. You have to, at this stage, really think big. We had what we called a spitball session in the early days, and we continue to have those sometimes. What do we want to do? What are all the things we're trying to get done? Throw those on the wall, start coupling them together and putting them into areas that are like, and then we prioritized what we wanted to try to get done. And what we felt like we couldn't get done the quickest, we would put in a parking lot. And as we could, we would pull things out of the parking lot. And to this day, on the laptop I'm speaking to you from, I have a document called the parking lot, and we've been at this for a decade, and we still have things in our parking lot. So it really gets into this. This is a long-term effort that really has no end. It's not something you can just kind of sprint out of the gate and say, we're going to do it, we got it, we're good to go, and feel like you get there. We also have used smaller work groups, which I would encourage you all to do. You can have your overarching group, but then these are the ones we have. You might have ones that are different, but what are some smaller, not too many cooks in the kitchen? Where are those areas of focus that you want to get some leverage, and let those groups go do their work and be able to come back and report out? The second pillar is around training and making sure, and this sounds so insane to me that we even have to talk about that, we would have competent, confident, and skilled workforce. People go to education programs and they get all of these classes and placements and all of these things, but we have a workforce coming out of a lot of educational programs that are ill-equipped, to say the least, in handling clients or patients that are suicidal. So we have to, as organizations, make sure we're cognizant of that, and that we are making sure that people have competency and skill up to a certain level. So you can do things like implement a workforce survey and ask them questions so you can evaluate how skilled your folks are. That can breed an annual training plan. So you can have clinical and non-clinical staff have some training requirements every year for whatever their role is, and definitely include the non-clinical staff. They interact with the people who come through your doors, and they see and they observe, and we try to make sure that everybody understands what their role is to play. And then for our clinical staff, we have to give them treatment-specific options. What are they using specifically that is a suicide prevention specific training? What are they using? What modality are they employing to help people who are suicidal, and not just treating the other conditions and thinking the suicidality will take care of itself if they only treat the bipolar disorder or the depression or the substance use. And trying to find training program that's consistent. You have to make sure it's cost effective and easy to access for the staff. We do an introduction for all new hires. We use a platform, a training platform. So they get a brief overview at new hire orientation. They have a follow-up training on a platform that really just says, if you work in our sandbox, this is how we treat suicide prevention, and this is how we expect you to treat suicide prevention. For the clinical staff, they also get about an hour and a half to 2 hours of additional training on this is what we expect your documentation to look like. This is what we're going to be looking for later when we audit your charts of patients you've had in the suicide pathway. And we really try to make sure we calibrate them on the front end so that they understand and know what we're going to be looking for. And then to be able to play in our sandbox, you have to know how to give the Columbia, you have to know how to do the Stanley Brown safety plan and access to lethal means. And those are all wonderful because they're easy to access because they're online, and they're very cost effective because they're free. So now you have a culture that feels about right. Hopefully you have staff that are prepared to do this dangerous work that we're asking them to do. So now we set about how are we going to identify all of the people coming through the door and pick out who might have issues around suicidality that we need to address. And this is, we view it just like when you go to the doctor and you get your blood pressure taken and your temperature taken, you know, regardless of what kind of medical provider you go to, from feet to head, you're probably going to get your blood pressure taken if you go in. And we see this really as the equivalent of that. So we start out, the first swipe you want to take is a screening. We do, I say all ages, we do about 10 to 12 years old with the tools that we use. And we do it in all programs. And we just want to make sure the staff are conveying to the patient, number one, why we're doing it. Number two, that they're comfortable if the patient wants to disclose this, that it's not going to freak them out, that they understand this could be a part of what's going on and that they're comfortable with it, and educating the patient on what that doesn't necessarily mean. If they divulge that, does it automatically mean that somebody's going to come and take you to an inpatient psychiatric hospital against your will? So we really see this screening as an opportunity for the staff to not just ask some questions and click some things, but to use it as a rapport building and an educating of the patient around this. We do it at intake and we do it at every subsequent appointment. I know some systems do it for a period of time, and if it's negative for a certain amount of times, they cease it for a while. You can surely do that. In our system, we do it at every visit and equate it to like a blood pressure check. We have daily and residential programs, so we obviously don't do it every time we see them because that would be irritating. And we just worked with those programs on it. PHQ-9 is what we use for a screening, and the Columbia is what we use for positive screens in our system. Our best friend, and I suspect your best friend, is your electronic health record. And that's maybe, you know, an odd statement to say because I've never met anybody, unless you're on Epic. Everybody hates their electronic health record unless you're on Epic. And I assume you guys are on Epic. So you probably love yours. But we embed as much as we can and lean in hard to the EHR to make sure it can help us. We embed the Columbia and the PHQ. So the clinician will see the PHQ. They'll complete that. If it's positive, the Columbia will pop up. That will be completed with the patient. And at the end of it, because an algorithm for the Columbia is embedded into, it always autocorrects to her, because it's coded into the electronic health record, we have a box that pops up with a recommendation about whether the patient should or should not go into our clinical pathway for suicide prevention. And that box is based on how they answered the questions of the Columbia. So it offers our staff some of that clinical decision support. They can choose to override it. We had some debate about whether we would let them, but we did land on the staff can override it. But if they do, whether they override it either way, put them in, it said not to, don't put them in when it said to, they have to document that justification in a text box that they type in. And then we run a report monthly to see how many times the clinicians overridden it, which way they overrode it, and what they typed in the justification. And if we see something wonky in the justification, we use those as education opportunities to educate the staff on things that they may be ill-informed about. So now you have them in, you've served the salad and the appetizer. All right. So you have a group of people that you feel like needs some kind of different care because of what's going on with them. And I really think the engage piece is the entree. It's the lobster tail and the filet mignon and the side of whatever potato. Like, this is it, because this is really the so what. So what, you've identified this person as being at high risk. How is their care going to look different because of that? And so you have to sit down and think about, okay, what can we do and what should we do differently because they are at high risk? So we base our placement in there on the Columbia and clinical judgment. Anyone, any level of our staff who's giving the tool can place someone into the pathway. So anybody that would be giving these tools can place someone in the pathway. When that happens, a phantom program, quote, I'm doing air bunny ear things here. It opens a fake program in the background, which allows us to run data of people in that program. So that's how we're able to capture all kinds of data, is because we have them lumped together in a program. It doesn't have billing tentacles and things like that to it. It's just a phantom program. The patient's name displays in red during the time they're in the pathway. And the system looks at the patient's services in the prior 90 days. And anyone that provided a service to them, it shoots out an email when they enter or exit the pathway. It's a high alert email that just alerts people, hey, you had somebody go into or out of the pathway. We didn't use alerts because people tend to often ignore them. And then we have a system where we have a team of folks that actually operate out of my crisis call center, and we contact them within 24 hours to follow up, see if they have any questions. Do they know when their next appointment is? And we confirm that the means have been reduced or restricted, because we want to close the loop and be pretty fanatical about the means piece so that we don't have folks with access. This is just a screen grab of our education sheet and a screen grab of the Stanley Brown safety plan. These are the two pieces of documentation that get used as an intervention during that first session when we have placed them in the pathway. So now we need to treat their suicidality head on. It's not a byproduct of, we're going to address this as the main problem on their problem list at the very top so that we can get to all of the other stuff. And this can be a difficult one for a variety of reasons. It is difficult in systems. I was talking with some of your folks earlier this morning. It's hard to find room in schedules to put folks into these slots, but we have to be mindful that they should really trump other folks who are more stable and doing better. And we need to press clinicians to either find space for them and shuffle other people around, or go to their supervisor if they're having a challenge doing that. But we should make sure they have a lot going on. And then it's also difficult in some ways to get some of this population to show for weekly therapy. We find a lot that we'll identify people, we'll get them into the pathway, but it's a real struggle to get them to come in weekly. And we try to talk to them about things that are preventative of them being able to come in and help them problem solve. And it's the usual suspect. It's copay and childcare and I'm not feeling well and, you know, all kinds of things, but really trying to strategize to get them in. We discourage medication only for this population. Can't force people to come in for therapy, but we definitely encourage it if they're in that medication only bucket. And we document that we're continuing to encourage them to come in. And if they won't, maybe asking alternate ways, could we call them once a week, or things like that. The treatment modalities that, seem to be the most popular, if you go to the Zero Suicide Institute's toolkit, you'll see all of the treatments that are really recommended around this, but the biggies you see are CBT and DBT, and some non-demand caring contacts where you either send postcards or texts or things like that, just to tell people, hey, thinking about you, hope you're doing okay. Not demanding anything of them, but just letting them know people care about them. We also internally built our own suicide prevention training that we're evaluating right now, because we have found bringing in some of these treatment modalities can be very expensive. So we're evaluating our own currently. So how do we transition people from one level of care to another? Historically, the system itself nationally, this is an area for a lot of improvement, because we don't do a very good job of this. Someone is inpatient, they leave, okay, they're not mine anymore, they just left the hospital, and the outpatient provider's going, hey, I haven't seen them yet, they're not mine. And we end up with this huge canyon that people are trying to cross over from one level to the other, and there's no bridge. And it's very, very dangerous. The statistics around these transitions of care are staggering. The multiple hundreds of percent more chance you have of dying by suicide the day you come out of the hospital, the week after, the month after. I mean, it's 800, 600, 200% more likely to die a suicide death after an inpatient stay. And we just don't talk about that enough, and we don't educate people enough around that. So some of the ways we try to kind of monitor the grid and make sure, people don't fall off of that grid, much like kind of an air traffic control, system. Planes aren't up there just flying around kind of willy-nilly. Somebody knows where every single plane is, and they get them from one tower to the next so that you can make your trip. We employ hospital liaisons, and other systems call them different things, but their office really is the inpatient psych units. And they go in there helping people who are going to come see us discharge out and come to us, so that we can make sure they know where to go. We can talk about who they're going to see. Hey, you're going to see Dr. Ed Boudreau. He's a good guy. He's got the skills that are going to help you. And there's somebody named Mary there at the front desk, and she's going to be expecting that you're coming in. Just trying to, again, be that wingman for someone in our system when someone in our system can't follow through and do the things that we would like for them to do, but the time constraints. We also set up a protocol that any hospital discharge has to be placed in the pathway at that first appointment. Regardless of what they say on any of the tools we give, if you're coming out of an inpatient stay, we want you in the pathway so that we can monitor your appointments, monitor your risk. So we automatically put people who are coming out of the hospital into the pathway. And then we just set up a protocol that, if someone's in the pathway and they call to cancel an appointment, the front desk staff can see that because their name is in red. And we don't let them just cancel the appointment. We ask them to speak to the on-call clinician just so they can make sure that it's pretty okay for the person to just reschedule and come in at another time. One of the other things, and the reason you want IT at the table with you, are things like this. We were having people not show for appointments, and then we can't get in touch with them in real time. So what we developed was, if the clinician that they're supposed to see can't reach them in, say, the first 15 minutes after they're late for an appointment, they go into our electronic health record and mark that they didn't show. And when they do that, our IT department programmed it so that that person's name goes over into a high-risk follow-up team who kind of is tagged in to track this person down. Doesn't mean we call the police and all that, but that we track them down. We keep calling them the rest of the day. If we have a release, we would call those people to really make sure that the person's safe. And we definitely have rescued people from suicide attempts doing this activity. And when we go over the education sheet, we tell them, please call if you can't come for an appointment, because we're going to pull out the stops and really try to track you down because we'll be super worried about you. People exit our pathway after a period of time, and it's because we give that Columbia, and when the results indicate that they don't need to remain in the pathway and the clinical judgment's there, we can remove them. Only master's level staff are allowed to do that, master's and up. So if I'm a bachelor's level case manager and the recommendation is they no longer remain, I'm going to consult with my master's level supervisor. And if everybody thumbs up, then we would exit them out and explain in the EHR why we're doing that. So I went to social work school in some part, not large part, but in some part because I don't like math. I'm not a Dr. Ed Boudreau. You know, numbers and all those things are not my super area of expertise, but luckily I work with people that it is. And I am the beneficiary of getting lots of data out of our system. So I'll talk to you for a second about how we like to improve our system. You know, one of the first things you have to do is decide how you're going to count suicide deaths. Who are you going to count? How long ago in the system did you see them if they die? And how are you going to confirm that their death was a suicide? You can see here what our definition is. And we get medical examiner reports and we work with the Department of Health to confirm that the death was in fact a suicide death so that we know we can count it. More importantly, or equally importantly, is we want to capture attempt data. You can do that really in two ways. You can get emergency department and claims data. That really is a little bit more restrictive because you're only getting people who sought medical care for that suicide attempt. You're probably more inclusive if you do a self-report, which you really can very easily capture in the EHR. You just ask people, have you had a suicide attempt since we last saw you? And you can click a yes and no button. You just have to make sure that you don't double capture those if you see people for multiple appointments in one day. We look at a massive amount of data in this space every month, and we have all kinds of reports. We want to know how many people are here. We want to look at our overrides. We want to make sure the staff are putting hospital discharge appointments in the pathway. How often are people scheduled and showing up? And the positive PHQ percentage. So you can make sure your staff is not, I mean, that's really the very beginning. If they're not getting it right out of the gate with the PHQ, you want to know it. And you want to make sure that they're not just saying, hey, you're not suicidal, right? And clicking no and no, that they're really using the tools. So see what their positive PHQ percentages might be. And then we look at how many suicides we had in that month. We look at a rolling 12-month and an annual rate. And then we look at kind of three buckets of the people that did die in our system. We know a lot of things about them, and we're looking for patterns. Is it a lot of individuals that have chronic pain? Is it a lot of people in a certain clinic? Is it a lot of people in a certain county? So we want to, you know, we're sniffing around to see if we see anything that we need to be cognizant of. And then we also look at data on our programs or service lines. Are we having a lot at a certain clinic or a certain program? And then we look at data on the providers. Are they doing the things we want them to do? And we have some reports around that. The last thing we do are fidelity audits. So 100 charts a month are audited of people who have exited the pathway. We have 4 people that do those audits so that they kind of keep themselves calibrated to where they're grading things the same. And then I'm going to come back. I'll jump back. But then the monitoring of fidelity looks like this. You get a score. And if you get green, yay. You know, yellow, we're going to try to coach you up. Orange, we're going to kind of coach you up. But if you get into this yellow, I mean, this red, and then that kind of weird below 39% red, you're going to go into a documentation needs improvement group. I call it the naughty list internally. I don't say that to the staff, but you're going to be in the group that's really not getting it done. And we see that as our responsibility to coach you up until you can audit yourself out, because you're providing documentation that is sound and following all of these things that we built. So let me just share a little bit of our journey in terms of data. The left slide shows that in the first about 2 years, it was about 22 months, we had a 64% reduction in suicide deaths after we started this initiative. And then as you can see, we had this weird increase that started occurring. And we were very baffled because we had been having such wonderful success. And we had our QI folks, and they called me one day and kind of had this aha. And the aha in that hump, that arc, was about 50% of the people that were dying in our system at that time were medication only patients. And they were only seeing us once every 90 days for 15 minutes. But by definition, they count. And so our medical folks put together a very comprehensive program pretty fast to address that, where we were vetting people harder before we allowed them to be medication only. And we were trying to start stacking appointments. So somebody agreed to come to therapy, you'd go to therapy at 9 and have your med appointment at 10. And what we saw, as you can see here, is it plummeted when we were able to address this medication only issue. And we've continued to not have that be an issue for us. Second thing I'll point out in this slide is there to the right, and we feel that this is very significant. Only 14% of people have ever died in our system in the pathway. So it appears that if we can get you into the pathway, it's very protective. And we, that's why we focus so hard on trying to identify people so that we can get them into something that appears to be protective to them. I also just wanted you all to see, we have so much data and they collect so many things, but we look at, things like suicide deaths in a month. And this is pretty indicative of what it can look like across our system. Is we usually have about 6 months out of the 12 that are zero. Almost consistently year over year, we can see this. This is an example of like by location, so that we can see here. This is Clarksville, Tennessee, home to the Army's Army Rangers, or some kind of high level security folks in the Army. So this would be of a concern for us. And then this slide over here to the right, we use this because this is kind of a meter for us. How many suicide deaths have we had over the last 20 years? And what months are hot? Well, it's July. We have mostly our deaths happen in July. And so we try to use that data to help us know that, okay, we might want to do some campaigning internally to get staff ready for what for us is not a great month. So I say all that, and have we had challenges? Yes, absolutely. You have to make these workflows very doable for the staff. And I really believe to do that, you have to talk to the staff. And we have to make sure that they understand we're not just piling more stuff on them, that we're doing life-saving work, just like happens on the medical side with some of these screenings. And if somebody has an elevated score, just like if I walked into the hospital or a PCP office and my blood pressure was 200 over 100 and something, that would be concerning, and they wouldn't really, they would probably pivot because I would have that. So we really have to work with the staff to decrease that resistance that they feel like we're just adding more stuff. Time for training can be very difficult. Once you can get your legacy staff trained, I really think you have that onboarding period, those first few months, and you can take advantage of the time constraints, but you have to get all of your legacy staff trained first to do that. We have to pay better attention to supervision and not talk about or provide training unless we're also talking about providing good quality supervision, so that the staff don't just get these trainings and we never talk about them again, and do that stuff. So I think these have been some of the challenges we've seen, and it's just a matter of like constantly staying at it, and making sure that this is of a top priority. So how do you do that? How do you keep this ongoing buy-in? I think you share a lot about it. You talk a lot about it. People should expect to hear from you about it, so that this really is like a living, breathing thing within the organization, and that you don't take anything else at higher priority. We have to keep people alive to take advantage of all the cool programming and wonderful things that we have to offer them. And if they're not here and not alive, that's not going to happen. And to do that, the staff have to see this as at the very core of what their role is, and that they have to accept that, and get into the boat with you so we can all row in the same direction. So how do we get that out of executive leadership? You know, they can proclaim we're going to do this and it's important, but we need them to follow that with action. Are they talking about it in meetings that they're in? Are they talking about it in the communications they put out? Are they asking us as the suicide prevention leaders about progress? And are they there for us if we say, look, I'm going to come to you when we're chopping down all the weeds to get through this forest. If we come up on a big boulder, we're going to come to you and see if you can help us move it. Do they commit to helping you try to do that? That's what we're asking of the C-suite. And then we have probably the most important group of all, these middle managers. And if we don't get their buy-in, we're sunk, because they're the ones really on the ground overseeing the operations. So are we seeing that they have more confidence in their staff's ability to do that, and that they're holding their staff accountable, and that they're giving us feedback, but they're also taking what we said and they're implementing it into their clinics? Do they really buy into it and take this on as the work we're doing? And then when you get to the level of the direct care staff who are doing the work, are we seeing that they're more confident and that they feel better about this and that they're really doing this in their practice? And the biggest, probably one of the most important things is, are we seeing a place where new staff are acculturating this? So when a bunch of new hires come into their clinic, are they like, yeah, we do suicide prevention, this is the way we do it, we're all in? Or do they really go, hey, we don't really do that? Like all that stuff you heard, that's not how we do it. If that happens, your legs are cut out from you. So we have to have all these layers where we're taking care of business, so that the staff really see this as a benefit to the patient population that they're serving. So I will stop there and see if Ed wants to field any questions. I know that was a lot of information and a lot of words, but glad to entertain anything that you guys have.
Great, thanks, Becky. That was really useful. We have some questions in the chat, and we can go through those, and then I think we can open it up for general questions from the audience. So there was one request for clarification, Becky, about entering the care pathway after a discharge from an inpatient admission. I think you said that would be even if they were not there for suicidality. Let's say they were there for a psychotic disorder or something like that and weren't suicidal. I think you said they still enter the pathway. Is that true? And how do you handle that with such a patient? You're on mute, Becky.
There's been a lot of debate about that, but our research institute came back and said to us, we think it's better if you put everybody in. It can be a risk. It may not have been the reason, someone, say, for example, has schizophrenia, but it still can be a risk and it doesn't hurt.
Yeah, I think that's consistent with the evidence that shows that many people who die by suicide have not recently endorsed suicidal ideation, but have had a severe or persistent mental illness and have been discharged from an acute care setting. So I think that's an independent risk factor. So it seems like it'd be a good idea. I wonder if there are challenges with having that conversation with the client, since the care pathway is oriented towards suicide risk, but the person may not identify as being suicidal.
And I think it also gets back to us, the leadership over this, equipping the staff with knowing what to say and educating them on, well, this is why we're doing it. And this is where you need to tell the patient we're doing it. You know, that there can be some risk associated. This might not have been why you were in, but just for a little bit of time, we want to put this protective cover underneath you. And if you don't need it, that's great. But at the end of the day, what does it do? It turns their name red, so we're more cognizant of it. It makes us make sure we're scheduling them weekly and hoping and encouraging them to show up. There's not really a negative. It's not like we say, if you're in the pathway, you got to sit in that corner, you know, and put a hat on that says path, you know, like it's nothing negative overtly to it. And I think you just have to make sure you equip the staff to be able to explain it and just not go, I don't know, they told us to do it.
Yeah, that's so important. And it reminds me of how the VA responds to their new algorithm that identifies individuals who are at suicide risk, who sometimes don't endorse suicidal ideation. So their suicide specialists are trained in that same way to reach out and to really focus on providing care and identifying care gaps, rather than focusing on the suicidal thoughts if they aren't in fact suicidal. So that sounds very consistent. Yeah. Nate has asked, does your pathway set up a better line of communication between providers and an expectation of some regular touching base with one another?
Yeah, the expectation is at treatment team, those kind of come to the top of the barrel, and you're going to. So, I mean, each clinic or program knows who especially the clinics, they know who they have in the pathway, and those are going to be priority to talk about during times like treatment team, so that everybody is working and you're collectively leveraging the whole system, and you got to talk about it.
What about providers who are not part of the treatment team of Centerstone? What about providers that are outside of the system?
Let me tell you, we've had a real problem with that. We get a release of information, but a lot of times they won't call us back. That we've had, I mean, I'll be candid, may I? We're friends, right? The problem is some of the suicide deaths that we've had this past year, there's been a few that were only getting meds from us, but they had an outside therapist. And we don't normally see that, but right now that's what we're seeing is, you know, yep, they're getting meds from us and they have this outside provider. And when we look at the record, we've reached out to them and it's crickets. And we're actually kind of noodling around on that right now a little bit, going, well, what should we do about that? If you have any ideas, send them my way, because what do we do if we reach out and they just won't respond back to us and go, hey, we're sharing a patient, we have a release, and they won't respond to us. And we've actually had some deaths of those patients.
Yeah, that sounds like a real gap, like that Swiss cheese you were talking about. Right. We face the same challenge here.
Yeah.
Another question from Alexander: are clinicians encouraged to routinely screen for methods of suicide, such as access to guns?
Oh, absolutely. Yes.
And that's part of the CSSRS.
Yeah, and it's part of going over the safety plan. I don't know if I told this group or if I told the group this morning. If I already said it now, just go like this and say, be quiet. But we did come up with some micro trainings that go along with our safety plan. So all of our monitors, or most of our monitors in most of the clinics, are like on a wall, and they'll pull the safety plan up. And we have a micro training that's about a minute long, and it's our Research Institute CEO, who's a clinician herself, explaining that section of the Stanley Brown. Like, here's what you're about to talk about, here's what we're looking for, and then the clinician fills it out. But you can use those micro trainings as much as you want or as little as you want. But we hope that while the staff are using those, that they're also learning. We're trying to get them to learn while they're actually doing it with Jennifer's videos. And one of them is talking about means and lethal lists and all that, and trying to get that stuff reduced or restricted.
I love that approach. That micro learning approach is just so smart. I'd like to try to do that here. Amy Harrington has asked about how all of this is reimbursed, and this is probably one of the most important questions. For example, the clinicians working with the patients transitioning from hospital to the clinic, are these clinicians employed by the inpatient unit? And if so, can they bill for the interactions?
Yeah, they're the clinicians that we employ. The hospital themselves don't employ. We employ them. They used to be funded by Medicaid, and then they took the funding away, and we were like, well, forget that. We're not going to do it. So we got rid of the positions, and then we were kind of like this. Wish we had those positions again. So now we fund them. They help with show rates. So they really do kind of pay. Now, where you can bill is sometimes they can do the intake like on the day of discharge. So you could have them do the intake for you and be able to bill those. And then when they go in for the first session, they're just seeing the clinician and the intake's kind of already done. So if you want to look to generate revenue, that's a way you can. Otherwise, I think you're looking for the sneaky ways. Are they paying for themselves? Well, they might be paying for themselves because you got more people showing up for appointments than would have if they weren't there. That's what we've seen.
That's a good point. Amy, did you have any follow-ups about this? I'm sure there's probably other questions related to reimbursement.
No, I have a million questions, but I mean, with telepsychiatry in Massachusetts, we're going to be able to do telephone visits in perpetuity, so and get reimbursed for them. So one makes me wonder if there's an opportunity there.
I bet there is. We should, yeah. If you want to set a call up or something, and
yeah, maybe something focused on this issue, because it always comes back to reimbursement and sustainability, because we can put together all these great programs temporarily. We can pilot it. We muster the energy for the short-term sprint, but the marathon is is really what we're running. And without that funding stream, we tend to peter out. So yeah, maybe we can do a sub focus, Becky, on that. All right, we're almost done. I want to get through one more. So Alan is asking about the denominator for completed suicides. Is this among patients at your clinic? Is it in a payer plan? We've looked at death certificates as a way to get feedback on patients who touch our system but don't stick.
It's anybody seen within our system in the last 90 days or has a future appointment. Is that the bottom number?
Yeah, numerator, denominator, yeah.
Okay.
Yeah, exactly. The denominator is all those who saw.
I told you, yeah, social work school, we didn't talk about that a little bit. But yeah, that's how we're looking at it. And you really just have to decide who you want your bucket to be. Mm-hmm. I've seen it all over the place. I mean, you don't want to go too far back, I don't think. Yep. I struggle sometimes with, it's hard to, you can build something and then you go, well, is it working? Like, here's this pill. And if you take this pill, you won't have this thing. And then we introduce people to the pill and then they don't ever show up again. Well, if they die, then you put them in your count, but they didn't get the thing. They didn't get the thing because they don't show, we've tried to look at that. And then that's where we were like, okay, they're in the pathway. They're not in the pathway, but that still doesn't, I don't know. We've been kind of thinking about that. And I equate it to a pill. Like, if you took this pill, you wouldn't have this thing. But if you don't take the pill, that doesn't mean the pill failed. Right. It means it failed. You failed to get them to take the pill.
I think a lot of places have used that 1 year look back. When you're running the data, was that person seen, touched by your system within a year of their death?
Yep.
I think we're at about closing time here. So if we had some other questions in there,
you can email them to me if you want.
Yeah, that sounds good.
You and I can do a call if you want. I'll just answer them and shoot the answers out.
Great. Thank you so much, Becky.
I hope the Celtics win. I'm pulling for your Celtics.
Yes. All right. We are too, of course.
Yeah. I hope they win. They tied it up. Yes. Or they're ahead.
They're ahead now. Yeah.
Everybody thought Golden State would just sweep them up, and you guys are scrappy.
That's right. So we're known for.
Yeah.
Thanks, Becky.
All right, see you guys.
All
Take
right,
care.
take care. Excellent
Bye.
presentation.
Thank you, Becky.
Yep, bye.